Good afternoon, students. So, today in the ortho lecture, we will discuss about the glenohumeral joint. The glenohumeral joint is the multi-axial ball and socket joint. We all know is anatomy that it is a ball and socket joint. That is, glenoid cavity and the head of the humerus form the glenohumeral joint. It is the most mobile joint in the body and its various components that is given in the following diagram, and that is it is made up of firstly the humeral head, labrum and the ligaments. That humeral head is approximately one third of a sphere and is oriented at 45 degree from the long axis of the shaft and retroverted the 30 degree. The indistinct anatomical neck consists of two important landmarks, that is, the lesser tuberosity anteromedially and the greater tuberosity is superolaterally. We all know that when we study the anatomy of the humerus, it has greater tuberosity and the lesser tuberosity, which are separated by the bicipital groove. The shallow shaded glenoid cavity is anteverted approximately and inferiorly angulated 5 degrees from the long axis of the scapula. So, this humeral head is a 45 degree from the long axis of the shaft and retroverted 30 degree. And there is a two tuberosity, that is lesser and greater. Lesser tuberosity is anteromedially and greater tuberosity is superolateral, and both are separated from each other by the bicipital groove. So there is a shallow shaped glenoid cavity is anteverted, which is approximately, and inferiorly angulated 5 degree from the long axis of the scapula. Then the labrum, it is the fibrocartilage, which is triangular in cross section and is attached to the outer perimeter of the labrum. So labrum is fibrocartilage. It increases the contact area by 70% and that help it to stability. So labrum is a fibrocartilage and which is a triangular in cross section. So it is attached to the outer perimeter of the glenoid and it increases the contact area by the 70%, so it helps in the stability of the joint. Then ligaments. Ligaments are the fibrous capsule is attached peripherally to the margin of the glenoid cavity and anatomic neck. So it has a three intrinsic capsular ligament called the glenohumeral ligament, which reinforce it. The coracohumeral ligament assists the capsule in supporting arm. So third one is a ligament, which is a fibrous capsule and is attached peripherally to the margin of glenoid cavity and anatomic neck of the humerus. So it has a three intrinsic capsular ligament called the glenohumeral ligament, so which is reinforced it, and the coracohumeral ligament assists the capsule in supporting the arm. So this is the diagram of the glenohumeral joint. In that you can see that this is a clavicle, this is the coracoid process of the scapula, this is a coracoacromial ligament. This one is supraspinatus tendon that is cut here. This is a coracohumeral ligament that is attached to the coracoid process and the humerus. This one is the greater tubercle. This is the lesser tubercle of humerus. This is the intertubular synovial sheath, which is communicated with articular synovial cavity. This is a subscapularis tendon. which is cut here. This is a bicep brachii tendon, that is the long head of the bicep brachii. So this is the anterior view where we can see the glenohumeral joint. In that, this is a capsular ligament. This one is a clavicle. Just below that there is a trapezoid part of the coronoid part of the coracoclavicular ligament. This is trapezoid part and this is coronoid part of coracoclavicular ligament. Then this is a superior transverse scapular ligament and the scapular notch. This is a coracoid process. This is the opening of subscapular bursa to the shoulder joint. This is the outline of subscapular bursa. So this is the anterior view and this is a posterior view. In that you can see that this is the deltoid muscle which is reflective. This one is the supraspinatus muscle. This is the subdeltoid bursa with the extension under acromion and the coracoacromial ligament. And these two are the subscapularis muscle. So this is a diagram of the glenohumeral joint, that is glenoid cavity and the head of the humerus. In this there is the rotator cuff. These rotator cuff, this is the name given to four interrelated muscles: infraspinatus, supraspinatus, subscapularis and teres minor. And by their coordinated activity, they provide it help in the finer adjustment of the humeral head within the glenoid cavity. So rotator cuff is made up of the interrelated muscles, that is infraspinatus, supraspinatus, subscapularis and the teres minor. So by the help of these muscles activity, they provide it help in the finer adjustment of humeral head with the glenoid cavity. Then the bursa. To provide a smooth movement, it is aided by numerous bursa of which subdeltoid or subacromial bursa is most important. It can carry out the various activities like flexion, extension, adduction, abduction, internal and external rotation, and the circumduction with ease. So, bursa provide the smooth movement. It aided by numerous bursa of which subdeltoid or subacromial bursa is more important. And it, due to the bursa, the flexion, extension, adduction, abduction, internal and external rotation, and the circumduction can be easily continued. Then next is a, so this is all about the glenohumeral joint. Then next topic is the dislocation of the shoulder. So dislocation is the very important topic. A dislocation of the shoulder, in that shoulder joint is vulnerable for dislocation more often than any other joint in the body. The extreme mobility it enjoys jeopardizes its stability. The shoulder has an Achilles point at the inferior part of the capsule, providing the joint with a potential weak spot. So much so that 99% of the anterior shoulder dislocation occur here. So 95% of the shoulder dislocation is anterior and the remaining 5% is posterior. So anterior dislocation of the shoulder is frequent, that is 95%, and posterior is very rare, that is the only 5%. So dislocation of the shoulder is very common in the injuries. So The shoulder has a Achilles point at the inferior part of the capsule, which provide the potential weak spot to the joint. So there is an anterior shoulder dislocation is caused. Masters identify two groups of the dislocation with the mnemonic tubes denoting the traumatic group and Ambry denoting a traumatic group. These are usually applied to the anterior dislocation but can be applied to the posterior dislocation also. So there are the two groups of dislocation, that is traumatic and the atraumatic group, which are applied to the anterior dislocation and also to the posterior dislocation. Then the main group is firstly we see that is anterior dislocation of the shoulder. So as mentioned earlier, this is the most common type of the shoulder dislocation. So mechanism of injury that it could be due to the either direct or indirect forces. The latter is more common, that is indirect forces. Varieties, the anterior dislocation of the shoulder could be either subcoracoid, subglenoid, subclavicular or intrathoracic. And among these, the most common variety is the subglenoid. So, in that, there is a variety of dislocation that could be either subcoracoid, subglenoid, subclavicular, and intrathoracic. So, in these, most common is the subglenoid. The clinical features are the patient complain of severe pain and inability to use the shoulder joint. There is a flat shoulder, rounded anterior prominence, and the arm held in a position of abduction and external rotation, and are some of the unmistakable clinical signs. So, due to the injury to the axillary nerve, there could be a loss of sensation on the outer aspect of the upper arm and is called the regiment bandage sign. So, other clinical tests are denoted in the box. So, in the clinical features, there is a pain, inability to use the shoulder joint, there is a flat shoulder, rounded anterior prominence, and the arm held in the position of abduction, and the external rotation are some of the unmistakable clinical signs. So, there is an injury to the axillary nerve. So, there could be a loss of sensation on the outer aspect and of the arm. So, it is called as the regiment band sign. In the radiographs, there are various views are required to detect the lesion due to the dislocations. So, this is a diagram. In that you can see the anterior dislocation of the shoulder joint. And in the second diagram, you can see the various varieties of the shoulder dislocation. So here in the diagram first, this is a acromion, this is clavicle, this one is a coracoid process, this is a torn capsule, below that there is a glenoid cavity, then this is the head of the humerus and this is the shaft of the humerus. And in the various varieties of the shoulder dislocation, firstly there is a subcoracoid, that is below this coracoid process the head of the humerus. So it is a subcoracoid. Then subglenoid, that is below the glenoid cavity head of the humerus dislocate. So it is called as the subglenoid. Then infraclavicular, that is just below the clavicle head of humerus is displaced. So it is called as the infraclavicular. Then posterior, that Head of the humerus is displaced posteriorly, so this is a diagram of the posterior dislocation of the shoulder. Then inferior, that is luxatio erecta, that head of the humerus displays inferior. Then this is a diagram of the regiment badge sign. In that, second is the different method of the reduction of the shoulder joint dislocation. So when there is a dislocation of the shoulder, the close reduction is essential. So there are the three types of the reduction. That is, first is a Siemens gravity method. So here we can see that how the Siemens gravity method is done. Then Kocher's method, that is most preferred method that used in nowadays also, that is Kocher's method by the close reduction of the shoulder dislocation. Then this is a Hippocratic method. Hippocratic method is outdated in nowadays. So this is a regiment that is sign. Then in this X-ray you can see the anterior dislocation of the shoulder. So this is the X-ray of anterior dislocation of the shoulder, and this is the X-ray of posterior dislocation of the shoulder. Then the treatment, that anterior dislocation of the shoulder is an emergency and has to be immediately reduced. There are the various methods of reduction, but the most commonly used method is the Koch's. That is this. This method is the mostly preferred, most commonly used method. So, in this diagram, Koch's method of the reduction of anterior dislocation of the shoulder, you can see that how the shoulder dislocation is corrected by the reduction, that is called as a close reduction. The method consists of the four important steps. That is, first is a traction, that is longitudinal traction, then external rotation, and A, that is adduction, and M, that is medial rotation. So it is called as the TEAM, traction, external rotation, adduction, and medial rotation. So this is very important in the clinical point of view, that how the close reduction of the anterior dislocation of the shoulder is done by the TEAM, traction, external rotation, adduction, and the medial. The various steps of these method of the reduction are under general anesthesia, that is GA. Longitudinal traction is applied along the line of the humerus, external rotation of the arm, adduction, and the internal rotation of the arm. So note that reduction should be gentle and should be done preferably under the general anesthesia, that is GA. So for the close reduction, GA is very necessary. Without the GA, the surgeon cannot or orthopedic cannot perform the close reduction of a dislocation of shoulder joint. Then the recurrent anterior dislocation of the shoulder, that is RDS, recurrent anterior dislocation of the shoulder. This is a very common complication of anterior dislocation of the shoulder and account for greater than 80% of the dislocations of the upper extremity. So, when there is a dislocation of the upper extremity, among that, this anterior dislocation of the shoulder is very common, that is 80% common. Age at the time of the initial dislocation is an important prognostic factor. Recurrence rate being 55% in a patient 12 to 22-year old, 37% in 23-29-year old, and only 12% in 30 to 40-year old. do you know? Did you know that one in every three anterior dislocation of the shoulder become a recurrent dislocation of the shoulder? So, initial dislocation prognosis is depend upon the age factor. That is 55% is 12 to 22, 37% is 23 to 29, and only 12% is between 30 to 40 years of the age. So causes of these are failure to immobilize the shoulder for 3 to 4 weeks after initial dislocation. Size and the nature of damage at the time of the initial dislocation. Greater the trauma, lower the incidence, and younger the patient, less is the recurrence. So when there is a immobilization of the shoulder is failed for 3 to 4 weeks after initial dislocation, and the size of the nature damage at the time of the initial dislocation. Then when there is a trauma is greater, then there is a lower incidence. And when patient is young, so recurrence is less. Then mechanism of dislocation. In the some individual, the dislocation can be predictable and can be avoided. In other, the mechanism is unpredictable and they thus make it a very disabling problem. The usual mechanism of dislocation is external rotation in abducted position. So, in the some individual, there is a dislocation is predictable, can be predictable and can be avoided. So, pathological anatomy is no single deformity is responsible for the recurrent dislocation of the shoulder. Three important regions have been cited and they have been called essential regions. Triad of the essential region, that heel sacs lesions. So it is a posterolateral defect in the head of the humerus. This is produced due to the impact of the posterolateral part of the head of the humerus against the sharp anterior margin of the glenoid ring. So there is a triad of these essential lesions, that firstly the heel snacks lesions, that it is a posterolateral defect of head of the humerus. So it is produced due to the impact of posterolateral part of the head of the humerus against the sharp anterior margin of glenoid ring. Then Bankert lesion is that Perthes first described this as a defect in the anterior part of the glenoid flap and the anterior capsule. So if this defect does not heal properly or heal in elongated position, so it results in a RDS, that is recurrent dislocation of shoulder joint. So in the Bankert lesion, there is a glenohumerus, glenoid and the anterior capsules and have anterior part had a effect, and this defect does not heal properly. So there is the recurrency in the dislocation. Then third one is the erosion of anterior rim of the glenoid cavity. There is the erosion in the rim of the glenoid cavity. External rotation of the shoulder is abducted position pops out the head of the humerus from the glenoid cavity. So due to the lax anterior capsular structures, the posterolateral defect now encountered the glenoid rim and is levered out of the socket, so producing the dislocation. And since no single factor is responsible for every recurrent dislocation, no single operative procedure can be applied to the every patient. So clinical features of that are usually patient gives the history of a previous episode of traumatic dislocation, and after that there could be one of two instances of repeated dislocation during abduction. The clinical features and the presentation will be like in anterior dislocation of the shoulder, but the far less severity, and there could be wasting of the deltoid, supraspinatus and infraspinatus muscles. So usually the patient have history of the previous episode of traumatic dislocation. So due to that there is a repeated dislocation during abduction. So there is a pain with the anterior dislocation of the shoulder, but there is a far less severity. And there could be the wasting of the deltoid, supraspinatus, and infraspinatus muscle. Then, clinical tests are there are the three tests. Three tests help to identify the instability of the shoulder which are prone to develop the RDS. The sulcus test with the arm hanging at the side stabilize the scapula from behind and pull the humerus down. So a large gap appears beneath the acromion, and this suggests the inferior laxity and is a test for superior glenohumeral and coracohumeral ligament. Then the apprehension test. So this is a diagram of the apprehension test. This is a provocative test where the arm is placed in abduction, extension and the external rotation. And if force is applied, the patient becomes apprehensive and resists provocation. So here is the 90-degree and this is 120-degree that arm is placed in the abduction, extension and external rotation. So force is applied, the patient becomes apprehensive and resists the provocation. Relocation test. The joint can be dislocated and relocated back into its position by the manual pressure. Investigation shows that there is a radiology, that is a study of a plain X-ray of shoulder, help to detect the various lesions described above. In the CT scan help to analyze the defect of RDS more clearly, and the MRI that help to evaluate the entire spectrum of the problem in RDS, namely the bony and the soft tissue, and the labral defect that cannot be identified by the X-rays, and these help to plan the better treatment. So, MRI and CT scan with the X-ray give the treatment mode of the line, that is how to plan a treatment. So treatment, there is the no role of the conservative treatment in recurrent dislocation of the shoulder. The patient is advised to avoid the abduction and external rotation of the shoulder. So however, surgery is the treatment of the choice and is indicated if the patient has more than 3 episodes of RDS. So remember student that when there is a more than 3 episode of the RDS, then surgery is the treatment of the choice because no role of the conservative treatment in the RDS. And more than 150 operations are devised. So all the surgeries aim at the correction of the essential lesions and prevent external rotation of the arm. Then the inferior dislocation in that luxurior erecta, that here the head of the humerus is below the glenoid cavity and the humeral shaft is pointing overhead. So it is due to the hyperabduction force and is a rare injury. So here the shoulder is located in 100 to 160 degree of the abduction with the forearm behind the head. So there is the inferior dislocation, that in that humerus is below glenoid cavity and the humeral shaft is pointing overhead. So it is due to the hyperabduction force and is a rare injury. So here the shoulder is located in 100 to 160 degree of the abduction with the forearm behind the head. So in this diagram, here you can see how there is an inferior dislocation of the shoulder blade joint. That is diagram E. Then the fracture of the scapula. So this is a diagram of the scapula. In that, this is a spine, this is the acromion, this one is a glenoid cavity, this is lateral border, this is medial border, this is the body, and this is the inferior tip of the scapula. The scapula is a flat bone thickly covered by muscles. So incidence is that it is a rare injury. 3 to 5% of all shoulder girdle injuries and only 0.4 to 1% of all fractures. So mean age is 35 to 45 years. The scapula have very low incidence of the injury. Then functions that st- scapula stabilizes the upper extremity against the thorax and links the upper extremity to the glenoid. So it stabilizes the upper extremity against the thorax and upper extremity to the glenoid link. Mechanism of injury shows that there is a direct blow, that is fall of a heavy object on the shoulder blade, and there is a axial loading on the outstretched hand. So there is a direct blow, that is fall of heavy object on the shoulder blade, that is this. So if there is a hello, हाँ हाँ, ठीक है. There is a axial loading on the outstretched hand. So when there is a direct blow to the shoulder blade or there is axial loading to the outstretched hand, then only there is a chance of the injury to the classifications is by the Thompsons, that in type 1, coracoid, acromion and the small fractures of the body. In type 2, there is the glenoid and the neck fracture. And in type 3, there is a body major fracture. Note that neck fracture is only 10 to 60%. Body fracture is 49 to 89%. Glenoid fracture is the 9%. Clinical features are the patient complains of pain, swelling, arm is held adducted to the side of the chest. All the movement of the shoulder, especially abduction, are painful, may be associated rarely with the pneumothorax, and inability to elevate the arms may give a feeling of pseudo rupture of the rotator cuff. So, the clinical picture is there is a pain and swelling in the scapula with arm is adducted and the side of the chest and the all movement of the shoulder, that is especially the abduction, is very painful and it is associated with the pneumothorax and inability to elevate the arm. So it gives a feeling of the pseudo rupture of the rotator. So this is a diagram of the type of the scapular fracture, that this one is a coracoid process, this is a glenoid, this is a neck, and this one is a body. So fracture if occur at the coracoid processes, glenoid cavity, neck or the body of the scapula. So in the radiograph, that is X-ray, shows a true scapular anteroposterior view and a true lateral view, that is axillary view, which help to make a diagnosis. In the treatment, when there is a non-operative method, that is undisplaced scapular fracture may be treated conservatively with rest, sling, straps, etc. An operative method, that is displaced fractures, need open reduction and internal fixation with the K wire and the screws. So, displaced fracture is present, then there is a K wiring or the screw. With the help of the screw, internal fixation is necessary. Then, next is the injuries of the arm. In that, there is a fracture of the shaft humerus, distal humerus fracture are included. First one, that fracture shaft humerus. So the humerus shaft fracture shows is the more common in adult than in children. And in the lighter vein, the humerus fracture is orthopedic surgeon friendly, and since it conceals his sins of improper management, an ideal fracture for a young orthopedic surgeon to begin his clinical practice with. The peculiarities of the humeral shaft fracture, that it is next to the clavicle. This is the most common second birth fracture, that is humeral fracture, and it is due to the surrounding thick muscles. The advantage of these are incidence of compound fracture is low, and thick muscles ensure to reach periosteal blood supply, and hence the fracture is invariably unique. So, the injuries of the arm consist of the two types of the fracture. Firstly, there is a fracture of the shaft of the humerus and distal humerus fracture. That is, the distal end of the humerus is fractured. And when there is a shaft of the humerus is fractured, it is more common in adult than in children. So it is uh, next to the clavicle, that this is the second most common birth fracture and due to the surrounding thick muscles. So advantages are compound fracture is low incidence in these, and thick muscles ensure rich periosteal blood supply, and hence fractures are invariably unit. Then margin remain concealed with the thick musculature. that is no cosmetic abnormality is seen. Concealed shortening of the humerus if any that disadvantages in that wide displacement occur. Wide displacement increase the rate of the malunion. Then malunion remains concealed within the thick musculature. There is a no cosmetic abnormality is seen. Concealed shortening of the humerus if any. And disadvantages are wide displacement in occur. Wide displacement increase the rate of the malunion. Then soft tissue interposition may occur causing non-union. Due to the ball and socket variety of the shoulder joint above, the malunion usually does not cause a functional disability. So gravity play a very big role in providing a sustained longitudinal traction force to the distal fragment, and this helps not only in the reduction of the fracture but also the retention. So these are the disadvantages that why displacement occurs. Then it increases the rate of myelinian, soft tissue interposition, and here, due to the ball and socket variety of shoulder joints, the malunion does not cause a functional defect. So gravity play a big role in this that help not only the reduction of the fracture but also there is a retention. Then shortening if occur largely remain unnoticed, and because unlike its lower limb counterpart, the femur, it does not produce the limb and hence there is the no functional impairment. So, radial nerve injury can occur before the reduction and sometimes even after close reduction. So, it is due to the getting trapped in between the two fracture fragments. And this is the only fracture in the body known to show this peculiarity. So, note is that muscle forces create malunion but also help to conceal. And gravitational forces which provide a natural fractional forces also may overdo it causing distraction and non-movement. So muscles reduce the incidence of compound fractures but produce all the varieties of displacement in the common simple fracture. Anatomic consideration gives that the muscles of the upper arm influence the deformity and if the fracture is in between pectoralis major and deltoid, the proximal fragment is adducted by the pectoralis major, teres minor and the latissimus dorsi, while the distal fragment is pulled up by deltoid. If the fracture is below the insertion of deltoid, proximal fragment is abducted by the deltoid, while the coracobrachialis, biceps and triceps pull the distal fragment up. So, this is the anatomic consideration. So, this is a diagram of deforming the muscle forces in a fracture humerus. That in the A, it is below the insertion of deltoid. So, this is the pectoralis muscle fracture below the deltoid. And in diagram B, that fracture is above the insertion of deltoid. So here, the deltoid is inserted. The fracture is above the insertion of deltoid. And in this, there is fracture is below the insertion of deltoid. So this is deforming muscle forces of the fracture of the humerus. Mechanism of injury shows that there is a direct force. This may produce a transverse or communicative fracture. Indirect force and is due to a fall on an outstretched hand, and this will produce an oblique or spiral fracture. So birth injury is the second most common birth fracture after the clavicle. So in the birth, there is clavicle fracture is most common, and just under humerus fracture is the second most common. The clinical features are a careful neurological vascular assessment is important. An injury to the radial nerve is common in this at the spiral groove or lower one third of the humerus. Remember, the radial nerve is running through the spinal groove and towards the lower one third of the humerus. So, injury to the radial nerve is very common in this. Then, in the radiograph, that is in X-ray of the entire upper arm, including both of the shoulder joints above and the below, elbow joint below should be taken. So it helps to study the level and the pattern of the. Remember in the X-ray, just above and below the elbow joint is essential. And in the treatment method, there is a conservative method that it consists of splinting the fracture if it is undisplaced. And in displaced fracture, splinting is done after close reduction, which is preferably under G. So it is using by the simple splint in birth fractures and simple sling may be sufficient in the young children. So these are the mode of the treatment or the method that is used in the fracture of the humerus. So in this lecture we will study about the glenohumeral joint, humeral hairs that it is made up of. This is a type of ball socket joint and it is a mobile joint that consists of humeral head, labrum, ligaments. This is a glenohumeral joint. That is the glenoid cavity and the head of the humerus. Rotator cuff and the bursa. Then the most important that is dislocation. Dislocation of the shoulder. In that anterior and posterior dislocation are the two types where firstly we was discussed about anterior dislocation of the shoulder, its varieties, clinical features, X-ray radiograph. Here is the diagram of anterior dislocation of the shoulder joint that it is acromion, clavicle, coracoid process, torn muscle, It is the glenoid cavity, head of the humerus, and the shaft of the humerus. So, when the various varieties of shoulder dislocation we see, it is the subcoracoid, then it is the subglenoid, infraclavicular, posterior, and the inferior dislocation of the shoulder. Then regiment bandage sign, then the different methods of the reduction, that is Siemens gravity method, Kocher's method, that is most preferred method, and the Hippocratic method is outdated. Then the radiograph which shows anterior dislocation of the shoulder, radiograph which shows the posterior dislocation of the shoulder, then the treatment, that is Kucher's method of the reduction, that is anterior dislocation of the shoulder. In that, the four important steps, that is traction, external rotation, adduction, and the medial rotation, that is TEAM. And then recurrent anterior dislocation of the shoulder, its causes, mechanism, clinical features, clinical test, that is apprehension test, is investigations and treatment, and the inferior dislocation of shoulder. Then we will discuss about the fracture of the scapula. That fracture of the scapula is a very rare incident. Its functions, mechanism of injury, classifications, clinical features, and a radiograph that shows the types of the scapular fracture, that is coracoid process, glenoid, leg, and the throat. And next is the injuries of the arm, that is fracture shaft humerus and the distal humerus fracture. In that, we was discussed about this, its anatomic consideration, mechanism of injury, and this is the deforming muscle forces in the fractured humerus, that is below the insertion of deltoid and it is just above the insertion of deltoid. So, X-ray, that is radiograph and treatment method, we was discussed in this. So, students, now we stop here. Have a good day and wish you a very happy new year.